come out of their body and either popped out or floated out, and then perhaps went down a tunnel and saw a being of light and felt a tremendous sense of peacefulness and love, and were met by relatives or friends who were deceased, and felt and had a life review in which they experienced their entire life from start to finish, perhaps a holographic kind of way, in which they saw every event, but as it was experienced by not only themselves, but what the feelings were of the other people that were involved. So if they were irritable with somebody, they would experience the feeling of hurt and shame or that the other person felt at the time. And then they're given a choice to come back, or they're told they have to come back. They often come back because they've loved someone who needs them here, or else because they've been told they have to come to finish their life purpose here. So I'd like to my talk today is generally about near-death experiences, but I also wanted to talk a little bit about the spiritual experiences as I look at them as a psychiatrist. Now, I know many of you are very familiar with spiritual aspects in my world of psychiatry. Some people are and some people aren't. Many people here can see visions and see the other realm, but many can't. Why is it that, how does this happen? And I began to think about the Magic Eye book. Are most of you familiar with the Magic Eye book?
Yes.
It was a book that was popular with, it's all dots, and as you put it up to your nose, and as you pull it back, you, at some point, all of a sudden the dots become a picture that's very, very detailed. Perhaps it's a seal or a camel, and everybody who looks at those same dots sees exactly the same picture, depending on the extent that they can get it. And I began to wonder if there was a sweet spot for seeing the spiritual realm. Because when you do this, at some point you see this whole elaborate picture, and you blink again, and then all you see are dots. And I'm wondering if it's the question of a focal point length, almost, for some people, or seeing a frequency. And maybe the spiritual realm can only be seen at that sweet spot. And perhaps there's a shifting focal point for children and for dying people, because young people often see deceased people, see a spiritual realm, and then they lose that at age 3 or 4. And we also know that when people are dying, they also are able to see the spiritual realm more easily. And I was thinking that when we come into this physical realm, we need to perceive the range of energy that will help us to cope in this physical realm. So we have to know that, for example, we can see the wavelengths of this table, so that we're not confused by what's spiritual and what's physical. And I think that we can use that metaphor of the sweet spot somehow, that we need to harden the perceptual things at age 3 or 4. Most people do, not all of you, obviously, but we need to harden that to cope in the physical realm. And then, as we don't need it so much, it loosens when we become closer to dying. Now, Dr. Jeff O'Driscoll is an emergency physician, and he has been seeing images of the deceased people that he has, spirits of the people that he's been doing CPR on in the emergency room. He's had this ability for quite some time, and people that he's done CPR and they decided to go on into the next realm have sometimes turned and looked at him and thanked him. And he's thanked him for trying or for his kindness. And he's also seen the spirits of other people that he hasn't been directly involved in their care, but he's seen their spirits in the emergency room. He kept quiet for many years about it, but decided to recently become public about it. And he's written a wonderful book called Not Yet. And he speaks of the veil, and he says our life, it's like we can imagine a curtain, such as here, and that's at one end, the curtain opens a little bit, and babies can come through into this world, and at the other end, the curtain opens a little bit, and our souls go on into the next realm. And it's as if the light of glory shines through on people that I suppose are geographically close, like in the emergency room, or people who are emotionally close. Now, it may not be a physical curtain, but that's a good image, I think, for us to conceptualize it. And I wonder, what is it about the curtain? Who can see it? Does it have to do with frequency, different mental frequencies that our brain is using at the time, or the sweet spot? I don't know. Now, another aspect of the interaction of spirituality and psychiatry is that of shared death experiences. When the healthy partner, or another person who does not have any illness, also shares some of the spiritual experience of the dying person. For example, those who are at the bedside of a dying person. The healthy person also sees the spiritual energies, such as the divine light, or sees the spirit leaving. So these kinds of experiences are really important, I think, to move the field forward, because we can't say, oh, well, the relative was septic or hypoxic or was under some influence that would affect him physically. So we're looking at phenomena that no longer need to be identified by a particular medical condition. So I think this is where the research is headed. And there's a program developed by William Peters in Santa Barbara, California, called the Shared Crossing Pathway Program, which is very interesting. He has dyads, or couples, working together where one is passing away or sick, quite ill, and the other one is healthy, and they attend a workshop. And basically, he focuses on intensifying the feeling of union between the couple, and having them focus on memories and choosing a memory that would be an anchor for them, so that when the theory goes, when one of them is going through the life review, and after they pass over, when they hit that phase in the life review, then that will trigger a telepathic communication with the relative. And he says he has a very high percentage, something like 86% of couples where there's some kind of spiritual event experienced by the second person. So I did that, took that workshop, and when my mother was dying, we focused on different memories and chose a memory to anchor it. Now, I can't say that I had an exact moment when suddenly I felt a burst of connection with her, but I think it's a very helpful program. There's more work being done in afterlife research, and Dr. Craig Hogan has an organization called the Afterlife Research and Education Institute. And he presents annual conferences, including ones with Sonia Rinaldi, electronic voice recognition. I think some of you are familiar with that, and Sherry Curl. And through that, one of those conferences, I became familiar with Induced after-death communication, and by Alan Botkin, and a similar program developed by Rochelle Wright. And in those programs, the concept is using talking to a person who is grieving, and using EMDR with that person, finding out what the grief statements were. They have the person who's grieving write out statements of grief. I'm very sad about this, or I'm reminded of my grief at this point, for example. And then what she did, Rochelle Wright does, is read the sentences slowly, while at the same time moving her hand, and at the same time was listening to sound, binaural sound. So it was actually quite overwhelming for my brain to be thinking of grief at the same time as listening to sounds, and and watching this. And I felt that, wow, I think it's overwhelming for the frontal lobe, and then what happens is perhaps one of the other brain structures takes over. What they have found is that when they were doing EMDR with patients, it's a form of therapy, that when they did a few extra sessions, the grieving patients would suddenly start seeing visions or experience hearing the voice of their loved one. And so when I took this workshop, I was curious, but that's how I experienced it. Now, again, a high percentage of people have had experiences of suddenly seeing visions or hearing the loved one. And I think, that's my theory, is that somehow all of this stimulation must be overwhelming for the front part of the brain, and the lower other structures kick in. But that's just my wondering. There is no definite, no clear understanding really of the phenomenon. We wonder about subconscious thoughts, or the role of the subconscious, and or hypnosis. So it's hard to understand these phenomena, but I'm just telling you a little bit about them because they have evolved from our interest in near-death experiences and wondering about how to contact or understand from the physical realm what the spiritual realm is about. Of course, many of you are interested in reincarnation, and there's several psychiatrists who've been involved in this over the years. Ian Stevenson with his reports of children, Brian Weiss who wrote Many Lives, Many Masters, and Jim Tucker, who has again been interested in children's experiences. So the references are in the slides, and I believe the slides are available for people later, or if you want, you can write to me, but I think they are available through the conference here. So what are some of these results in thinking of looking at near-death experiences and afterlife communication attempts? And well, there has been a whole paradigm shift in how we view consciousness and mental illness. And first of all, the biggest change is that we no longer are seeing so clearly have such a strong sense that the brain creates consciousness. There's now beginning to be an understanding, even in medical circles, that the brain does not create consciousness. The brain is the hardware, and consciousness is the software. So, and we can think of the brain as being like a television, and the software is, the consciousness is the program. But beyond that, the brain actually acts as a filter, and Dr. Fennick was talking about this yesterday. And we know that the more prolonged the cardiac arrest, the more expansive the NDE consciousness is. Geographically, people seem to be able to see more or have a greater sense of understanding from different perspectives. And they also come back with a greater amount of new learning, new information. So that's why we say that the more prolonged the arrest, the more expansive. I guess you have to be careful how you say that, because I said to one reporter, well, as the brain was shutting down, the consciousness increased. And I thought, when I saw it in print, oh, that looked ridiculous. It was like I'd never seen a comatose patient. Didn't I know better that their consciousness wasn't increased? But I think it's like a TV shutting down. When the TV's on the fritz, the program really, you don't get much of the TV program. And when finally the TV shuts down and you take the program elsewhere, then you get the expanded consciousness. Why do we think also that the brain is a filter? Or what would be the implications? Well, if we didn't have the brain to filter out energy, and we would be overwhelmed with cosmic information. So we only need the frequencies for our physical survival and physical living. So also with near-death experiences, it helps, there must be a change in how we approach psychosis. As I mentioned yesterday, I was raised with the biochemical model that when people were psychotic, that it must be completely biochemical. But when I thought of Dr. Ritchie's account as written in Order to Return, and he is also featured in that video, Life After Life, by Peter Shockey that I referred to earlier. that changed my thinking a little bit, or began to open my mind, I should say. And I'm going to just quote this because it is so interesting that he said, a man carrying a tray came toward me and said, "Watch where you're going." I said, "He acted as though he could neither see nor hear me. He walked right through me." Dr. Ritchie then found himself flying overhead and came down to ground near a cafe, later identified in another city, where a second man walked right through him. Then he saw a bright light and said, "Stand up, you're in the presence of the Son of God," and he experienced a life review with the Christ. He was taken by the Christ to various realms, including to a tavern. I could see civilians having a good time drinking their alcoholic drinks. I could see other beings who were experiencing the same difficulty I had. Their hands went right through the glasses. Then they would stand up and watch in great anguish. From time to time, one of the human beings would become totally intoxicated, which caused the electrical field of aura to separate. And that's what I said yesterday. It was like a zipper, perhaps, starting at the head and going to the feet. When this would happen, one of the less dense beings without the aura would try to beat out the other similar beings getting into the human being through the separated electrical field. I gathered that these astral beings had become alcoholics when they were living on the earth. The only way they could enjoy feeling intoxicated again was to enter a human's aura. So he understood the need to overcome addiction while still alive, and so he worked with alcoholics for the rest of his life. So what are the implications of that? His account was cohesive. Was he misled? Or are the biochemical paradigms of illness overly simple? If human beings can walk through discarnate souls, well, this suggests that discarnate souls can occupy the same space as human beings. So what kind of energies may be passing by or through us? So I know this is old hat to most of you to all of you in the Spiritist community. However, it's very almost heretical in the medical scene or in more traditional settings. So that's why I'm just bringing this up. For psychiatrists, this is a very novel way to look at it. So does this relate to spiritual warfare or influences? So, and I thought, well, perhaps discarnate souls are entering the bodies of human beings when they're not in control due to psychosis. Now, most psychotic schizophrenics do not commit horrific acts. And most are really lovely human beings that are suffering with a terrible illness. And yet every so often you hear of some horrific act of murder or bizarre horrific behavior. And I'm wondering if at those times an entity has entered into the psychotic individual. And I mentioned yesterday the core symptoms of schizophrenia of thought control, thought insertion, thought withdrawal, thought broadcast also really overlap with what we know about possession or discarnate souls entering. So I'm not denying the validity of biochemical abnormalities, but I think we need to modify the paradigm of how we see psychosis. Could there be an additional potential for spiritual energies to influence symptoms in an unprotected brain? So if other entities can enter, does this modify our interpretations of multiple personality disorder or reports of demonic possession? So how do we interpret these phenomena? Well, I think in the medical context, carefully and strategically, but with growing awareness of possibilities. So that was more or less what I wanted to cover yesterday with spiritual implications, and now I'm going to move on at great speed over what I want to cover today. So we talked about what the NDE is, so I'm going to move very quickly. And about near-death experiences. And I want to talk today about, at this point on, about clinical situations where we can benefit and help our patients benefit, help our friends benefit from application of the wisdom from near-death experiences. Some of you are in healthcare, but not everybody is, but we all have friends and relatives who are struggling in life, and we can help people. first of all, it's important that we recognize and validate a near-death experience for a person who's had one. Because people keep these experiences very private because they fear that they will be scorned or that they will be considered naive or perplexed or humiliated. I recently gave a talk, just last month actually, at a conference about near-death experiences. And after the conference, this woman came to me and she said, I wasn't actually attending your conference. I was at one of the booths outside in the hallway. And she said, you talked about doctors or other people making the person who's had the experience feel very foolish. She said, 34 years ago, I had an experience. And it wasn't the doctor who put me down, it was my mother. And I've never mentioned it to anybody until now. And she gave me a big hug because she felt validated for the first time in 34 years about her experience. So it is so vital that we really appreciate these experiences and validate them. They are so common, as I had mentioned. We talked a little bit about the angel yesterday. Now, there are various contexts in which I'd like to talk about the application. And one of them is recognizing a near-death experience because sometimes the person who's had one doesn't recognize that they've had one. I was asked to see a 22-year-old young woman because she was anxious. That's all I was told. She'd had a stem cell transplant for leukemia. So I said, well, why are you anxious? And it was thought that she had survivorship issues about her coping. She said, well, I'm afraid about dying. I'm having images about dying. And she said, I'm worried that these are premonitions that my leukemia is going to recur. She also worried that such negative thinking could lead to a recurrence. She said, if I'm having images of dying, maybe that's going to bring my leukemia back. So I took her medical history, and she said that during her hospitalization, she'd had a cardiac arrest when she was unconscious, and that she'd been resuscitated but had no recall of it. So I said, okay, now tell me about your images about dying. And she said, well, actually, I keep thinking of myself at the foot of my bed, like when I had the code, and I'm watching the code being called, and I can tell you which nurse came in and did what and what they were wearing, and she described the code totally accurately, and as if she had been watching it. She had never heard of a near-death experience. She was an atheist, and she had no paradigm with which to explain these images. So because I knew about near-death experiences, I could say, well, you actually had an out-of-body experience. And I think that these memories have been repressed and they're just coming back now. I said, your experience was valid and legitimate. Your brush with death had already happened and was unlikely a premonition. I didn't want to discuss parallel universes with her. I just, for all purposes, it had happened. And that these images weren't actually negative thinking at all, that they were memories and they did not increase her recurrence risk. I said she'd survived the code and was still alive for some purpose. So now her focus could now move from illness worry to determining what her life purpose was. She was alive for a reason, so let's focus on why she's alive. So she had some trouble integrating this awareness because she was really considered herself to be an atheist. Her identity centered around her identity as an atheist. So I felt she's still young, and she's at that developmental stage in life where she's trying to consolidate her identity. And perhaps as she navigates the developmental stage of consolidating her identity, she might be able to grow out of this more narrow self-percept and see that she can move on to see herself in a broader way. I mean, as teenagers go through life, they often think of themselves as the cool person or the jock or the nerd, and then with more life experience, they see themselves more broadly, and I see that's what's going to happen with her, and maybe she can see herself more broadly than as an atheist. And I think that as she does, more memories of her near-death experience will surface. Now, where else can we apply the wisdom from near-death experiences? Well, obviously, for people who are afraid of dying. Awareness of near-death experiences is a way to introduce the topic of death and to reduce the fear of dying in a way that is intriguing and hopeful. So this is what I say to people. Now, remember, I work on the leukemia ward, and where there's a lot of unexpected death or hoped for survival and then sudden recurrence. I've also worked for many years with patients with metastatic cancer who are frightened. And so this is what I commonly say. Well, have you ever heard of a near-death experience? No. Well, a near-death experience is what people experience when they come as close as you can get to dying and still survive to talk about it. And what they tell us is that the actual moment of dying is peaceful, regardless of what it looks like on the outside. And beyond that, it raises the possibility of a spiritual realm. You may choose to accept the spiritual possibilities or not, but we do know that the moment of dying is peaceful. And so that opens the door to talking about it. And I always emphasize the contrast between what the person's experiencing on the inside and what it might look like on the outside. And I say there's an example of a man who was electrocuted, which might have looked quite violent to somebody watching, and yet what he described inside was a feeling of utter peacefulness with the sound of chimes and an orderly quality to the experience. So whatever it looks like on the outside, we know that the person inside is feeling peaceful. This is important to reinforce. I had a patient who was actually the father of a young man who died on the leukemia ward. The young man was 19. The father had been an atheist. The young man died in a hospice, and he got up and suddenly had a heart attack or faltered and fell towards the father. The father was horrified, and he actually had features of post-traumatic stress disorder. He was reliving that scene over and over. And so I said to him, well, what we know from people who come as close as you can get to dying and still come back and talk about it is that your son was feeling peaceful inside, even as his body was collapsing. And it looked a lot worse on the outside to you as he felt inside. And I said, beyond that, it kind of reminds me of childbirth, because women go through labor and then the child is born, but then they don't dwell on the labor as the child grows up. They move on. And I said, your son, whatever he experienced at that time, which I believe was likely peaceful, he's moved on, he's enjoying the other side, the other realm. So I don't think he wants you to be stuck reliving that second over and over. And the father was so thankful that I could tell him about near-death experiences. Sorry, it makes me choke. Because he gave up his atheism, his beliefs changed. He became very interested in the whole next realm and started sending me videos and things that would be useful. So that was a very healing thing for him. Sometimes people who are dying have dreams, and those can be dream equivalents of a near-death experience. I had one patient who told me, I had the most amazing dream last night. I popped out of my body and went down a tunnel and saw a being of light. Now, he didn't have a near-death experience in physical measurement or observation, but he had a dream equivalent. And he said, I no longer feel afraid of dying. And I've had a few patients like that, and they died with total confidence. I also wanted to talk about the importance of, another story I want to tell you about is a young 28-year-old woman who had a transplant and then relapsed. And she wanted to know what it was like to die. So the staff said, well, we'll call the palliative care team to help you, because she knew she only had 2 or 3 weeks left. And so the palliative care team came and said, well, your breathing's going to change, you may feel colder, and like she was horrified by the end of it. They told her what it would be like physically. And I happened to come by an hour later and I said, well, and I heard about this, and I said, did they tell you what it felt like on the inside? And she said, no, other than these features. And so I said, well, I can tell you about near-death experiences and what people have, what they really experience on the inside. And it totally transformed the whole scene. So her thoughts of dying went from being very macabre and being buried 6 feet under and nothing to face but bleakness, to, oh, there's going to be a celebration on the other side, and it could be interesting. And I promoted the feeling, as Dr. Finnick talked about yesterday, of being curious. And so her husband, I suggested she watch that film, Life After Life, by Peter Shockey, which really gives a good experiential feel of what it could be like. And she and her husband watched it, and she said, oh, this is kind of interesting. And we started talking about her uncle who was on the other side and how he was such a jokester and how they could have fun together. And she started looking forward to the reunion they would have. She did die several weeks later, but that whole next 2 weeks, she lived with a feeling of, okay, I'm going to a party, I'm going on a trip, and she was really able to come to some sense of peacefulness and acceptance of what was happening, with a greater sense of hope than she had been when she was left with just the physical word about what her body was going through. So it's so important that we give hope to people who are dying, and this is one way we can do it. As mentioned yesterday, it's common for people who are dying to see visions or dreams of loved ones arriving to welcome and escort them to the other side. Now, Dr. Christopher Kerr, in his TED Talk, suggests that we say, have you had dreams or visions of loved ones who have passed over coming to see you? And I've done this frequently with my patients, and including my mother when she was dying. The day she was dying, I said, do you see anybody here? She could no longer talk at this point, but she was still with it to some degree. And I said, do you see your parents? No. Do you see my dad? Yes. So just to make sure that there wasn't any mistake here, I said, do you see your parents? I asked her again. No. But you see Dad? And she had this big grin on her face, and a few hours later she passed away very peacefully. I was called to, or I was told that an acquaintance was in a hospice, and I thought, well, I'd go see her, but I thought she had a few weeks to live. Well, I got there that evening, and we had quite an animated conversation, and I asked her if anybody had visited her, and she'd been seeing her deceased brother in her dreams. And I said, well, he's waiting to celebrate you with you, and what a celebration it's going to be. I told her about near-death experiences, and I quoted the lyrics from Going Home, the spiritual, but Mom was waiting there and Papa is there too. And I showed the husband how to do a little bit of therapeutic touch to make her feel relaxed. And I said, well, I'm not sure when you're going to go, and I'm not sure when I'm going to go, but if you get there before I do, then I hope you'll welcome me. And if by some chance I get there before you do, I will certainly welcome you. But otherwise, I'll see you next Saturday. I didn't want to not say goodbye, but I didn't want to force the issue and make it dramatic. So she said, well, that would be great if you can come back on Saturday, and thanks. And she was very, very bright and animated, so I thought, well, I'll probably have a couple more visits with her. So I left, saw her husband in the parking lot 10 minutes later, and he said, oh, she's gone to sleep, so I'm coming back in the morning. She died in her sleep 3 hours later. She never woke up. So I think that telling her about the celebration and reassuring her gave her such hope that she was able to peacefully let go. So that was quite the story. I was quite surprised, actually, that she died several hours later. We've talked a little bit about the shared death experiences. So I'm going to move on. We can also use near-death experiences therapeutically in other situations. And I talked the story of people who are grieving their own anticipatory losses. Because when people die, they're saying goodbye to everything. You may be saying goodbye to the dying person, but they're saying goodbye to everything in life, their home situation, and this can be trigger other grief. And so focusing on hope and celebration and what's next can be a helpful thing, I think. Also, it can help with spiritual dilemmas. Jackie was the born-again Christian who I mentioned yesterday, was afraid she would never see her husband again, and her pastor said that you probably won't, and she went to her GP. So how I used the near-death experience in that point was, I said many Christians have had near-death experiences, and I suggested that she consider thinking outside the box, and that God could come up with a solution much greater than we could think of. And this satisfied her and gave her greater peace of mind about her husband's future and that she'd see him again. But the doorway, or the technique to access that and was by talking about near-death experiences and that Christians had had them. So she was able to accept that, and then we could move beyond the narrow thinking. Sometimes I've talked about near-death experiences to relatives of people who've died. My patient Paul was dying of throat cancer, and as he became more ill, we talked about his spiritual beliefs, and he said, well, maybe I'll go somewhere after dying. We talked about near-death experiences to give him some greater focus, some ideas, and increased hope. Neither of us knew, but it would be our last appointment. After his death, 2 weeks later, I met with his sister, in which she felt reassured by learning that he had said, well, maybe he'd go somewhere after dying. And she derived some comfort herself from watching the video with me about near-death experiences. And I told her, well, I watched that video with Paul also before he passed away. And that gave her a connection because she was connected to me with this video, but because he'd seen it just before he died, she felt, okay, well, I'm experiencing some of the thoughts that he had before he died. So it was kind of a link, a nice linkage. And she felt kind of calm and reassured in her grief. Now, the next one is probably one of the most important areas that we need to be using near-death experience wisdom with suicidal patients. And suicidal patients do not appear just in emergency rooms or to psychiatrists. They can appear in any setting. They can appear in an outpatient setting, such as the young mother I saw 3 weeks ago with chronic life-threatening blood condition. She was battle-weary. She wasn't accomplishing much, and her self-esteem had dropped. She had no previous faith, no life purpose. Her marriage was strained. They were all exhausted, and she was thinking of killing herself, and she had 2 little children, 5 and 7. Just earlier, a few weeks earlier, I had a young father in his early 30s saying, if my leukemia comes back, I'm going to kill myself. He had a 6-year-old daughter who adored him. Now, people can also have suicidal ideation who may be in your circle of friends or family. And so it's important that that this message is understood by everybody. It's not just for healthcare professionals. You've got to trust your intuition. And if you really think somebody is, then you've got to act on it. And be encouraging. But if you're unsure, send the person to emergency or go with them to emergency. But what I say to people in this situation is, it may feel as if it's hopeless, even though the reality is not hopeless. It may feel as if it's hopeless, even though the reality is not hopeless. I want everyone to repeat that with me. I'm going to say it one more time. It may feel as if it's hopeless, even though the reality is not hopeless. Because if you say, the situation's not that bad, yes it is. No, it's not that bad. Okay, you're right, but inside they're saying, yes it is. And then they just argue, people will argue with you. And they'll just say, you just don't understand how bad it is. So if you feel, it feels as if you're no longer fighting with them, you're agreeing with the person, it does feel that bad. It feels as if it's that bad, even though the reality is, it isn't. So you slip that in, and it's a subliminal way of giving hope to people. And I also say, harming oneself could be a disaster of permanent effects and tragic effects for what is very likely a very transient situation or transient mood. Then, I often tell patients about near-death experiences, and I'll say this is what we know from people who have tried to harm themselves, and that there is a spiritual realm. We are known very personally and loved by a spiritual force, or higher power, or God, who is aware of our circumstances and life events. Our lives do matter and have individual purpose and meaning. Loving others is most important. And so for that father, I said, your child needs to know she's loved. And your child needs you. She needs you. You're her only father. And even though we don't know what the future holds, but you will always be her father. And if you exit early, it can send a lifelong message that she was not worth living for. Even that you gave up three weeks earlier than you needed to. And she might interpret it that she was not valued enough. So parents don't often think that. I also said that to the other woman. And I said, look, what we know from near-death experiences is that you do matter. And I also then tell the story of, I'll just leave it on this slide for a minute. I tell the story of Sandy, who's in that video, and she was a nurse who shot herself in the chest, and that survived. She had a cardiac arrest, and police were called, but she had a near-death experience. She watched the policemen come, she watched the ambulance attendants come, she wanted to argue with them that they were getting some facts wrong, and that she watched her body being taken out on a stretcher to the ambulance, and she followed the ambulance to the hospital. And she said she felt very loved, and she said to this being of light, where were you? And the being of light said, well, I've been here all along, you just couldn't see me. But she said she felt so loved, and she didn't want to come back to her body. And she was told, you can stay in the spiritual realm, or you can go back. But if you stay here on the spiritual side, you will have to go through every amount of pain that you've gone through in the earthly life, and then go from there forward. She said, wow. She said, I thought back about my life, and there'd been some good moments, but there'd been a lot of pain, and I didn't want to have to go through that again. So she said, I learned that there's no point in cutting your exit short, because it's like dropping out of a grade 10 partway through, and then you have to go back and start at the beginning of grade 10. She didn't say that, that was my analogy. But you have to go back to the beginning and go further on. She said, you're not saving yourself any problems by doing that. So I have used that story many times with people who are suicidal, and I say, this is what I've learned from people who've had these accounts, and this is the story of Sandy, and this is what she said. So I don't know if it's a good idea. I don't think that you're going to help yourself by exiting early. And so what I've written here, the possible consequences to suicide are having to redo life's pain or challenge. And I said, and what if you get on the other side and you say, oh no, I've made a mistake, but it's too late now. So that's another comment I make. So I used that story of Sandy with Lara. And Lara had fluctuating suicidal ideation, and but I told her about Sandy, and the comments had such an impact that she went home and thought about it, came back a week later, and I said, have you had any more suicidal thoughts? And she said, oh, I didn't dare think about acting on those suicidal thoughts after what you told me. She said, I don't want to go through all of this trouble again. So that was that. And she has not been suicidal over the number of years since that occurred. And I'm glad to say. The fellow that I told you about, the father, he did not commit suicide. He hung in there. He spent the time enjoying every moment he could with his daughter, and he died just a few weeks ago. But his daughter saw him the day before she died, and he was her hero. So I think we have a role about teaching about near-death experiences to patients in the emergency, in inpatient and outpatient settings, and in suicide prevention clinics. I want to talk about my group that I had with women who were dying of metastatic breast cancer. They came every week for 90 minutes from the time they registered in the group until they died. It was a study to see if they would live longer if they were in a support group. And they learned from each other. It was an amazing experience. I led that group every week for 6 years. The first one who died had wanted me to give the eulogy at her service. And so that set the pace. From then on, all of the patients and all the women in the group and myself would go to the service and sit together, and then the next group we'd talk about it. We had an angel mascot that was given to the group. It sat in the group every time, and it sat at the front of each celebration of life. And it was a reminder of the spirit of the women and angelic presence. In that group, there was a woman who said, she had 3 small children, and she said, every day I can live longer is one more day my children have a mother. And I never forgot that, because at the same time, there was a woman lobbying for medical assistance in dying, who also had a young son at that time. And I thought, what a contrast. If I were a child of either of those mothers, which home would I rather be in? A home where the mother was fighting to leave earlier, out of feelings of wanting to be in control of her life, and I understand that, appreciate that the mother was feeling a sense of lack of control and wanted to determine when she died. But would I want to be the child of a mother who was fighting to leave me earlier, or the child of a mother that says every day I can live longer is one more day my children have a mother? I've used that quote with many of my suicidal patients, including those 2 leukemia patients I just told you about, the mother and also the young man who had the children, both of them who had young children. And both of them went eyes widened, and they said, no, I'm not going to commit suicide. And I've emphasized that even with a terminal illness, a parent can demonstrate being a hero to children as his or her legacy. Our actions matter. And I also say every additional day lived might be just enough for a new drug or a cure. And I sometimes tell the story of my father, who was told that he went to the doctor and found he had a very high white count and was told he had 3 weeks to live, and which was a bit of a shock. They phoned me and said, "Are you sitting down?" But in fact, he found out the next day that the diagnosis was a different kind of leukemia, and in fact there was a new drug that had just come out within the past 6 months, and this drug revolutionized the treatment of that form of leukemia. And my father died 11 years later of a completely different cause. So every day that you can live longer or keep going might be just enough time to change everything. And sometimes I do use antidepressants in low doses because I feel that when people are that stressed, and including in palliative care, that it can just reset the biochemical state that their body is in and can increase resilience, and that's how I put it. It will help you feel that you can cope a little bit better. But that's not for everybody. But sometimes people do have symptoms of depression in that context, as well as dealing with all of the other aspects of dying. You might say, of course, people might be depressed in palliative care, but some people have a clinical depression in addition to what everything else they're dealing with. And not everybody who's in palliative care has a depression, for sure. People can be terminally ill, they can be tired, or weary, or excited about the next realm, or accepting, but not necessarily depressed. Sometimes we can give hope from a spiritual occurrence. I was at a conference a couple of years ago, and a man with psychic abilities, medium, said, someone you know has recently had tuberculosis and he's withholding information from you. It's important you discuss this with him. I went back the next day to my city because I knew there was only one person I'd known who'd had tuberculosis recently, and it was a leukemia patient who had reactivated TB because he was immune suppressed. So I told him that I'd been approached by this man, and my intuition told me to ask him, what is it you're withholding? Are you suicidal? I previously asked him in appointments, but he always stated he wasn't. He broke down and told me of his desperation the previous week, and he felt that his teenage daughter was rejecting him, and that was the last straw. And he felt his life had no meaning. He's Chinese, and saving face was important to him. But he couldn't believe that I was onto this. And he said, how did you know? And I said, well, this is what I was told, that to ask you that there's something being withheld. And I said, I'm not accusing you of not being honest with me, and I'm not incompetent, it's just that we needed to explore some issues further. And when he thought about it, he said, I can't believe that God loves me so much that he would send somebody from Florida to my therapist from Vancouver, and that we would meet in Scottsdale, Arizona, and he would give you a message about what I was up to last week. He said, I can't believe that God knew everything I was thinking last week. And so this was incredible to him, that God loved him that much, and that God knew everything that was going through his mind. So he felt loved, he felt understood, and he said, wow, I guess my life must have some purpose if God cares about me that much. And so as a colleague said, well, the life was saved. If I hadn't had that experience, who knows? I mean, he'd been denying the suicidal ideation to me. So, now how else can we use near-death experiences? We can use it for spiritual development. Sometimes we can use it to when a person is not specifically religious. And this is one way that you can share spiritual growth without proselytizing. And this is a big concern in hospitals, and certainly in North America we're not allowed to proselytize or to talk much about religion. But this is a way that we can talk about it. These are experiences that people have and that you should know about. And so we can underscore the possibility of a greater purpose in life and a greater context for understanding one's suffering. Maybe there's some potential meaning beyond what we know, what you're going through right now. I want to tell you about my patient Mary. Mary was an atheist woman in her 80s with a narrow life view. She had a history of cancer, and that's why I had seen her. And there was a multi-generational history of relationship difficulties. She was always getting into arguments with her daughter, and her daughter was with her, and she had with her mother. And at one point I said to her, I think you're from a line of prickly porcupines. She kind of laughed. But I think it was really multi-generational depression, and they were all very rejection sensitive and perceived rejection very easily. So my therapy was eclectic. I tried to address pertinent medical, psychological, social, and spiritual factors. So I looked at the medical and mood factors. I prescribed tried various antidepressants in various dosages to decrease her sensitivity to rejection and criticism, because I thought maybe we're looking at a symptom of chronic depression, which she's chronically feeling punished or persecuted. Psychotherapy focus included her childhood issues and helping her to develop some insight into her ways of perceiving herself, the world, and others. I tried to broaden her egocentric perspectives regarding relationship battles with her grown children. How would your daughter see this? Maybe your daughter sees it differently from the way you see it. I advocated for at times in the clinic and tried to bolster her medical and psychological approaches to the physical challenges that she had, such as shingles pain, and she had for one. I prescribed a little bit of clonazepam, which really can be very helpful for those of you who are doctors. I encouraged her to broaden her social network. She said that and spiritually, I tried to encourage her to read and to attend a religious organization she had once attended because it had social advantages. She'd attended a particular organization, didn't hold those beliefs, but thought it was a good thing. So I said, well, maybe you should go back and try that. I suggested she read Life After Life by Raymond Moody. She wasn't convinced. So then I suggested she read about the experiences of children in Closer to the Light. I mean, we also talked about it. She came to her next appointment with a more open mind. She said, after all, children haven't been exposed to as much religious propaganda, but they even had similar experiences. Maybe there's something to this. Several months later, she was diagnosed in her 80s with metastatic illness, and yet she faced her situation with peacefulness and a new sense of serenity and of hope for her future that was nudged along by her new knowledge of near-death experiences. I couldn't believe the timing of that. I'd seen her for several years and had made little progress, but I felt that the timing for me to introduce the topic of near-death experiences was divinely led. You know, because I had no indication when I did introduce it that her cancer would return. It returned shortly after, and she died in a hospice a mere 2 to 3 months after the topic was initiated. And in those months, she was much more contented, more philosophical, and less angry than in the previous few years. She now had a greater sense of meaning and perspective for life's journey. She could see that there was a broader way of looking at things, and she was hopeful of the spiritual realm. So those are ways that we can use the stories in various contexts, when people are afraid of dying, have a fear of dying, when they're actually in a terminal situation, or when they're suicidal, or when they have feelings of a lack of purpose in their lives. So, and what are some of the other resources that we can help or encourage with patients? Well, I mentioned the shared death experiences therapy. Sometimes I talk about reincarnation-based therapies. And we talked a little bit about Afterlife offshoots with Brian Weiss. Linda Bachman also does work with past life therapy, as well as Brian Weiss. She does past life regression and between lives regression. And in these past life regression therapies, basically they use clinical hypnosis, which is focused attention to attain a relaxed state. That's all that hypnosis is, by the way, for those of you who are nervous about it. It's just focusing on a singular focus and then letting other things go. And that's why it's very useful in pain management, by the way, because people focus on a trip to Hawaii, or they focus on sitting by the seashore or imagining the sounds, and they tune out all the other stimuli. So past life regression uses hypnosis to help people feel very relaxed, and then they go back and tend to spontaneously, with a little direction, recall past lives and lessons learned. Now, what about afterlife communication? This has been kind of a new thing for me in attending these conferences and learning about it, and I know Sonia Rinaldi from Brazil has been involved in this and using electronic communication with other people as tools or mechanism to receive messages from the other side. not just with Sonia Rinaldi's work, but I've had people say to me, well, my loved one, my spouse told me they'd come back to me after they died, but they haven't come back, and I feel very deflated. And my comment is that I think sometimes grieving relatives are sometimes so intensely grief-stricken that they're less likely to perceive the presence of deceased relatives. And I think grief maybe affects the ability to perceive spiritual energy. And I'm thinking along the lines of what I talked about, shifting that perceptual sweet spot of focus. Or maybe it dampens the functioning in the temporal lobe somehow. When you're depressed, you lose faith. And if you're depressed, what's happening? Are you dampening those anatomical structures in the brain, or the pathways involved with mood and spirituality? And I wonder if grief also affects those pathways. And so then somehow, if you're dampening the temporal lobe functioning, the right temporal lobe functioning, maybe along with dampening faith, maybe you're dampening the ability to perceive spiritual energy. Sometimes people have experienced that when their grief lessens, then they're more likely to have a visit from the other side. But I know I should be walking with tiptoes here because I'm talking. You're the expert. Many of you are the experts in this field more than I am. And I've talked a little bit about Rochelle Wright's therapy and my thoughts about that. So I've actually combined some of the talk from yesterday, so that's why I'm looking at some of these slides with a little surprise. Now finally, I just want to address education. Near-death experiences are actually, it's like a taboo subject in medicine. It's not a regular topic in medical schools. It's not a regular topic in palliative care training, nor in psychiatry programs. It's unbelievable. It's not a regular topic in trauma or emergency settings, and it's rarely on the medical conference agendas or in educational rounds. So I know Dr. Bennett spoke at the palliative care conference several years in Canada, but that is so rare to have that kind of acknowledgement. And why is that? I mean, it's quite shocking. I think it's fear that it could be politically incorrect to discuss religion or spirituality. I think there's confusion that a near-death experience is a form of religion. And in North America, it's like there's an allergy to religion. And so what I think we need to do is to explain that near-death experiences are they're psychospiritual events. They're experiences of people. They're not part of religious dogma. And I think that's the way that we can bring spirituality into the medical context, by saying it's a profound experience that has psychological and spiritual consequences. We need to acknowledge it. Our patients and our friends or family are experiencing these things. We need to know as much as the general population does, and we need to understand these phenomena so we can help patients. So I was on the palliative care ward a couple of weeks ago, and I looked at the library they have there for the patients and the relatives. I was horrified. It was like, we will never recover the loss of Lucy forever. Grief, in black grief, men's grief, and it was all about grief and bereavement, and it was sickening. And there was one book by Maggie Callahan about final words that people have before they're dying, along the lines of Christopher Kerr's TED Talk. But that was the only one. There was nothing for the patients themselves to be reading. I thought, my goodness, we need to have something uplifting here. So I think, and it struck me while I was there. I went to see one of my patients, and he said he was anxious, really worried. And I saw spiritual care had visited him, and they'd done some deep breathing, but that was it. And I thought, deep breathing, he's afraid of dying. We need to talk about near-death experiences. experiences with this man to let him know what people experience who come that close. And he felt quite relieved when I talked to him about it. But I thought, if I don't tell him, it's like malpractice. I mean, if I thought he had an infection and I withheld an antibiotic or didn't give an antibiotic, people might say, well, that's incompetent. So why are we not saying in palliative care situations it's medical malpractice or incompetence if we don't give people hope of what might be a possibility and of what other people have experienced? So I'm becoming a rebel. We need to teach the next generation of healthcare providers, and there are recommended videos, near-death experience, what medical professionals need to know by Roberta Moore, it's excellent, and Life After Life video by Peter Shockey, The Afterlife by Paul Perry. These are all good videos. And these are on the slides. I'm going to move along. And we need to teach the other healthcare professionals. Many healthcare professionals are totally naive about death and spiritual considerations and are left to come to their own perspectives on the issues, sometimes from a spiritual vacuum. Their perspectives are going to have subtle and not so subtle effects on how they persuade patients to come to decisions in facing situations, such as what I've observed to be subtle coercion to sign do not resuscitate orders, or to really promote medical assistance in dying. So, I mean, these issues are there. I mean, no one wants to admit that there's subtle coercion, but I've seen it. And we need to bring education to all areas. These are all different areas in the hospital: emergency, acute care, ICU, renal, cardiac units, surgical units, palliative care units, naturopathic clinics. But, not everybody here is a healthcare professional. We can all do our part in educating our friends, our relatives, when they're afraid of dying. Just, talking about these things, and it provides a way that's not religious regarding whether you're a spiritist or how you approach things. It's a way that we can access it. So, I'm going to just finish at this point and say that one woman who was approaching death stated, "I feel a bit anxious, but then I'm always a little bit anxious when I start a new journey. And perhaps I should be, as Dr. Fennett suggested yesterday, adopt an attitude of curiosity. I should be curious." Thank you very much.
First question, should people on antidepressants for many years, should they change to a new medicine?
Well, if they're depressed, definitely they should change to a new medicine or have the dosage reassessed. But if people have been stable and doing well on it, then they might want to, and if there's a long-standing previous history of numerous depressive episodes or a family history of depression, they might want to go very carefully in considering whether they want to decrease it or whether it's helping them cope as it is. What I often suggest at that point is just to taper it down a little bit and very slowly and see how they do. And if they're fine after a month or two, then taper it down a little bit more. And do it very carefully. After all, the body has probably readjusted to a new equilibrium of having that medication, and you don't want to trigger a rebound by stopping the medication too quickly. But some people actually are on antidepressants for many years and they cope well with that. Oh, did anybody hear any of that?
You speak very clearly. I don't think you need microphone at all.
But you're 10 feet away.
Okay, next question. It's an interesting question here. From a person who would like to know, do you have any idea how many people in the audience have the phenomenon of hearing voices or seeing discarnate spirits?
Okay, yes, I'd like to know. How many? Who? I suspect it's even higher.
How many people in the audience have had the experience of hearing voices or seeing discarnate spirits?
So that's pretty.
Have a look around, please.
So,
Does that answer your question?
and how many have had a near-death experience or have had an out-of-body experience or have had someone close to them who has? Yeah. It's common. Yeah. And yet it's not talked about that much. I do want to caution people that some psychiatrists are open, like Dr. Rediger and hopefully myself, but not everybody is. So you have to be careful and use your intuition in who you tell what. Because I don't want people to go off and say, okay, it's a new era and psychiatrists are more open, and then get hit, tell somebody who's not really open, and it creates problems. So I'm just concerned for everybody's safety.
Thank you. I'm not sure, I've got a question here for Dr. Lane and Dr. Felipe. I'm not sure if he's in the room any longer. Please describe similarities you have found amongst people who experience out-of-body experiences as a child. For example, do you find that they have greater spiritual awareness, more relaxed, or more stressed? Is there any patterns there?
Well, I would think that people who've had out-of-body experiences in childhood or in adulthood would be more open to the sense that there's a spiritual realm, or that they don't identify their souls as being totally tied to their bodies. I mean, I guess that's evident, but I think they would probably have a more spiritual sense of their identity. I think it's very interesting the number of people who've had flying dreams. How many people here have had flying dreams where look at that. They're so common. And yet, I mean, psychiatrists don't know about them, but I remember one, I just loved it, flying. I thought I was in a hang glider flying over the western part of Calgary. And then I've had helicopter dreams where I felt that I could angle up, and I remember one dream saying, oh, don't think that you can't do it. If you think you can't do it, you'll just drop. So, but they're very common, as evident in the room today.
Next question. People generally seek new drug trials or groundbreaking treatments as a means to reach cures for terminal illnesses. How can we incorporate a spiritual approach as a viable option to heal the dying body?
Well, I don't see them as being mutually exclusive, generally. I think people do much better with hope, and sometimes people feel hope if they have another consultation, see somebody else, and they learn something that they could try. We have to be very careful, though, that people don't get taken in by clinics that are willing to prey on people who are willing to pay tons of money for a cure that's very unlikely. But other than that, I encourage sometimes people to get a second option. I had one patient who left the clinic, and she was supposedly terminal, and 6 years later I bumped into her at a conference, and she said, hey, Dr. Drysdale, it's me. No, you haven't seen a ghost. I'm still here. But she had hope. She sought a second opinion, and she tried something else, and who knows whether the faith that the other medication would work. I mean, faith, belief is a very strong, powerful trigger for healing. We know about the placebo effect as well, and the placebo effect is like an amazing thing. It's the sense of that the body can heal itself, or belief that the body can be healed. So it's very complex, but I suggest that patients do what they can medically, and I also suggest that they do what they can spiritually, whether that's going to their church service, seeing their pastor or rabbi or whomever, or go to prayer services or 12-step programs I encourage. And by the way, 12-step programs are interesting. The first step is considering the possibility or feeling I can't control the situation. The second is maybe there's a higher power, spiritual being, and the third is asking for help. And I think asking for help is a very key spiritual force. When you look at a lot of conversions, it's when they've asked for help. And I'll tell you, I ask for help every day. When I'm with patients, I'm with a patient, I say, man, I never learned how to deal with this in medical school or in psychiatry or in conferences or lectures or reading since. This is a unique situation. What should I say? And then the words pop into my head, and the patient will suddenly say, how did you know? That's exactly what I needed to hear. Well, it was the divine helping me. So I frequently ask for help, and that's when things usually go the best.
Alternative antidepressants. Then the person goes on to mention a few of St. John's work and trial plan and their effect.
Well, St. John's wort is actually a selective serotonergic reuptake inhibitor, so it's a mild form of most of the SSRI drugs, such as citalopram, escitalopram, fluoxetine, fluvoxamine. So it's really just a mild version, and it has side effects. There's drug interactions with it. There can be really bad drug interactions with it, and you don't always know the dosages that you're getting. So I tend not to suggest that with patients, because particularly as I work in an area where patients are taking so many other drugs, and I don't want to have drug interactions, and I've seen it happen. So. And the other one is tryptophan.
And just their effectiveness in general.
Tryptophan is sedating. It's a precursor to serotonin. So I've had one patient, actually the son of a patient, who was taking massive doses of tryptophan in a product, and he's been having terrible times. I think he's getting intoxicated with it, and then he's going through withdrawal from it, and he's having muscle problems, and I've had major problems with the hospital he's not directly my patient, but trying to get him admitted to the ward and having this dealt with. I'm sure that this is what's causing his problems. And by the way, just because something's natural doesn't mean that it's healthy. I mean, I remember as a resident being in Emerge, seeing someone with anxiety and heartbeat irregularities, and they'd had a lovely foxglove salad and had eaten massive amounts of it. Well, foxglove is the ingredient for is basically digitalis, which is a heart medication, and if you take too much, you're going to have problems. So, I mean, things can be very natural, but very poisonous too if you take it in the wrong doses. And for some things, the correct dose would be 0.
Thank you, Lane. Next question. Could you say a bit more about working with fragments of experience? For example, like that creature that crawled up your leg.
Thanks, Mick. Mick and I were talking about this and wanted to ask about it.
So I mentioned earlier about having a sense of, at one point, having this reptilian creature. I was wide awake in this bed and just feeling like my dog used to walk on me, and I felt like that. And I thought, my goodness, I'm not mentally ill, I'm not septic, what's going on here? And that's when I prayed, and then it disappeared. And it reminded me of another time I was doing a work, participating in a workshop with Brian Weiss, a psychiatrist who does past life regression therapy. And he does a common experience, little session with people where he has them go into a trance, get relaxed, and they imagine what shoe they're wearing on their left foot, and they look down. And I looked down, and there I was wearing a left pilgrim's brogue that belonged to a man. And I thought, this is like a Dutch brogue from a pilgrim. And I thought, wow, this doesn't seem like it belongs to me at all. I don't think I've had a life as a male Dutch pilgrim. And then I thought, this is very strange. I had lots of memories and experiences with previous life, and memories throughout my life of a past life in Vermont, and I'm familiar with that, but this seemed weird. And then I thought about it. Where was I? I was in upstate New York, and New York used to be called New Amsterdam, so it was Dutch pilgrims, and I was presently at that time in the town of Rhinebeck. And I thought, oh, I must be picking up a thought fragment or something from somebody that was here. It felt like I'd been going through the dirt and picked up a pottery fragment, and I thought, it was like saying, well, that pottery fragment never belonged to me, it's just here in the dirt. And I felt like throwing it away. It was just a fragment I picked up. And I wondered about that reptilian feeling that sense I had of a reptile crawling at me. Was that just something from dinosaur eras gone past on the same property? Or was it some evil thing? So we don't know, and I'm not an expert in reptilian energies, so maybe it was an energy, but it also got me thinking about thought fragments that we could pick up from previous energies and lives.
I think the term you were looking for there was reptilian interdimensional species.
That's what I meant to say. Thank you. Reptilian interdimensional species.
Thank you, Elaine. Final comment here before the coffee break, and Ali has something to say. The final thank you for Dr. Elaine comes from many of the audiences. Thank you very much for such an inspirational talk, and also thank you for teaching us caution.
Oh, good. Well, I hope that I have taught both caution and courage. And I look at people in the room like Dr. Fennick and others who've been very courageous in moving forward and in sticking their neck out at times, and that has forged the way for others to come forward. So I hope that I leave you both with thoughts of caution and courage.
Thank you very much.